Now, let us discuss heart failure. Heart failure is a clinical syndrome of cardiac pump dysfunction, which means the heart is unable to pump blood effectively. This results in two main problems: congestion of blood and low perfusion of tissues. The symptoms include shortness of breath, which we call dyspnea, difficulty breathing while lying flat, which is called orthopnea, and also fatigue. The signs we find on examination include an S3 heart sound, rales in the lungs, jugular venous distension, or JVD, and pitting edema, which means swelling of the legs that leaves a pit when pressed. There are two main types of dysfunction. The first is systolic dysfunction, also known as heart failure with reduced ejection fraction, or HFREF. In this condition, the end-diastolic volume is increased, but the contractility of the heart is reduced. This often occurs due to ischemia, myocardial infarction, or dilated cardiomyopathy. The second is diastolic dysfunction, also called heart failure with preserved ejection fraction, or HFPEF. Here, the heart's compliance is decreased, meaning the heart walls are stiff and cannot fill properly. This leads to an increase in end-diastolic pressure. A common cause of this is myocardial hypertrophy. Right-sided heart failure most often results as a consequence of left-sided heart failure. However, when right-sided heart failure occurs due to a pulmonary cause alone, we call it cor pulmonale. For treatment, we use several groups of drugs: ACE inhibitors, angiotensin receptor blockers, angiotensin receptor, neprilysin inhibitors, beta blockers. But remember, beta blockers are avoided in acute decompensated heart failure, and aldosterone receptor antagonists. These medications have been shown to reduce mortality in HFREF. In addition, loop diuretics and thiazide diuretics are mainly used for symptomatic relief, such as reducing fluid overload. Hydralazine combined with nitrates and also SGLT2 inhibitors can improve both symptoms and mortality in select patients. Now let's look specifically at left-sided heart failure. Orthopnea means shortness of breath when the patient is lying flat. This happens because when lying down, there's an increase in venous return due to redistribution of blood by gravity, and this exacerbates pulmonary vascular congestion. Paroxysmal nocturnal dyspnea refers to sudden breathless awakenings from sleep. This occurs because of increased venous return when the patient is lying down, along with reabsorption of peripheral edema fluid back into the circulation. Pulmonary edema results from an increase in pulmonary venous pressure, leading to pulmonary venous distension and transudation of fluid into the alveoli. In the lungs, we may see hemosiderin-laden macrophages, also called heart failure cells. Now, moving to right heart failure. One sign is congestive hepatomegaly. This means the liver becomes enlarged because of increased central venous pressure, which leads to increased resistance to portal venous flow. Over time, this can rarely progress to cardiac cirrhosis. On gross exam, the liver often shows a mottled appearance, which we call nutmeg liver. Another finding is jugular venous distension, or JVD. This occurs due to an increase in venous pressure, and it is easily visible as distended neck veins. Finally, peripheral edema is another hallmark. This happens because of increased venous pressure, which drives fluid transudation into the interstitial tissues, causing swelling in the legs and ankles. Now let's quickly compare HFREF and HFPEF on graphs. In heart failure with reduced ejection fraction, HFREF, the main issue is decreased contractility. So, For any given end-diastolic volume, the heart generates lower pressure and lower stroke volume. In heart failure with preserved ejection fraction, HFPEF, the problem is not contractility but reduced compliance. The stiff ventricle cannot fill properly, so even with normal contraction, the end-diastolic pressure is higher and filling is impaired. Finally, let's talk about compensatory mechanisms in heart failure. When cardiac output, or CO, falls, the body activates several systems. Neurohormonal stress increases sympathetic tone. This releases catecholamines. Beta, 1 adrenergic stimulation increases contractility and heart rate, while alpha, 1 adrenergic stimulation increases arterial tone and venous tone. This maintains blood pressure and increases venous return to the heart, also called preload. Simultaneously, the renin-angiotensin-aldosterone system becomes activated. Angiotensin II causes vasoconstriction, while aldosterone and ADH increase circulating blood volume. This further increases venous return to the heart. Together, these mechanisms try to maintain blood pressure, cardiac output, and stroke volume in the short term. However, over time, they contribute to deleterious cardiac remodeling, which worsens heart failure.